All right, we're going to go over chapter 9, the cardiovascular system. So we're going to look at the heart and some structures around the heart and what makes up the heart. Heart consists of the heart itself and blood vessels. The heart pumps blood throughout the body, and the vessels transport blood throughout the body. So you can see this picture here. The blood goes from the superior vena cava to the right atrium, right ventricle, out to the pulmonary arteries, to the lungs, left atrium, left ventricle, aorta, and then to the rest of the body. The heart itself is it's a muscular organ, so it's a muscle. It does have a hollow interior that consists of chambers. It pumps blood through the body. It has the two chambers, atrium on top, and the lower ones are ventricles. The right atrium is on the upper, obvious right side, and left atrium is upper left. Right ventricle is below the right atrium, and the left ventricle is lower. They're divided, or the heart is divided into the right and left portions. The interatrial septum separates the atria, and then there's an interventricular septum that's going to separate the lower chambers, the ventricles. Valves open and close with each heartbeat to maintain the one-way flow, so the blood flow doesn't back up to the heart. We have the tricuspid valve, which is between the right atrium and right ventricle. The mitral valve, often called bicuspid, located between the left atrium and left ventricle. And they're kind of like a leaflet looking. Pulmonary semilunar valve is from the right ventricle going out to the pulmonary artery, and the aortic valve is located between the left ventricle and the aorta. So this kind of gives you a picture here of seeing the atrium and the ventricles and how the valves open and close. So you can see the right atrium and then that tricuspid valve, the right ventricle, and then the intra-atrial septum there, and then up to the blue portion, the pulmonary artery. And then you can see the left ventricle. Again, it's going to be the body's left side. The heart itself has layers. So those layers are three. The endocardium is the membrane that lies interior cavities of the heart, and the myocardium is a little bit thicker. It's the muscular layer, and the epicardium is an outer layer. Those are the three layers, but there's also a protective sac around that called the pericardium. It's pretty loose, and it surrounds and encloses the heart, helps protect it. When we look at some of the vessels, arteries carry blood from the heart to the arterioles, and arterioles are small vessels that receive blood from the arteries. The aorta is the large artery branching from the left ventricle. Capillaries are tiny vessels that join arterioles and venules, and venules are small blood vessels that gather blood from the capillaries into the veins, and veins carry blood to the heart from the venules. Here's a picture of looking at some of the main arteries. So often when somebody has a heart attack, which is a myocardial infarction, it's going to involve one of these major arteries. So right here, like we have the example would be the left descending artery. We have the right marginal artery, left anterior descending. Those are common areas where we have infarction, which means lack of perfusion. The blood's not getting through, it's blocked. There's another picture of the blood and lymph circulation. So deoxygenated blood from the body enters the heart through that superior vena cava and the inferior vena cava in the right atrium. And during atrial contraction, that tricuspid valve opens to allow blood flow to the right ventricle. And then the contraction of the ventricle pushes blood through the pulmonary valve into the pulmonary artery. And the pulmonary circulation is the passage of blood from that right ventricle through the pulmonary artery to those lungs. And then the blood will get oxygenated there and come back through the pulmonary veins to the left atrium. Contraction of the left ventricle pushes blood through the aortic valve into the aorta to all parts of the body. The coronary circulation supplies blood to the heart, which is the first organ to receive the oxygenated blood via the right and left coronary arteries. Here's a picture of arteries. You can see how they're made up of the tunica, media, externa, endothelium. subendothelial layers, and internal elastic lamina. In the middle, there's a normal picture of an artery, so blood flow would go through if you look at the angiography, the picture. And then below it is abnormal. There's plaque buildup in there, so you can see how the redness doesn't go all the way through. There's blockage from that plaque, and that's what would lead to a heart attack or a stroke. And veins are a little bit different. Arteries are red blood that's not oxygenated. A person can easily bleed out. You very rarely will bleed to death from a venous bleed, but you can see here on that Doppler blood flow showing the arterial blood flow and the venous blood flow. But you do have to have venous blood flow to have good perfusion, so oftentimes like in a femoral vein, and it's kind of in your groin area, if you don't have adequate blood flow, your legs can turn blue and often lead to amputation if they don't have circulation. When we look at measuring blood pressure, that's the force exerted by circulating blood on the walls of the arteries, veins, and heart chambers. It's determined by the volume of blood, the space within the arteries and arterioles, and the force of the heart. That blood pressure cuff is a sphygmomanometer. So sphygmomanometer, it's hard to say, so we often just call it a blood pressure cuff. When we read the blood pressure, we're going to have two numbers, diastolic and systolic, so the lower number and a higher number. So when we look at blood pressure, it's often said to be normal is 120/80, but it depends on the actual person. So some people are abnormally low, and that's their normal. Diastole, the diastolic, is the period in the cardiac cycle when the blood enters the relaxed ventricles from the atria, and systole is the period in the cardiac cycle when the heart is in contraction and blood's ejected through the aorta and pulmonary artery. When we say somebody's normotensive or has normotension, that's normal blood pressure, or hypotension. Remember, hypo is low blood pressure, and hypertension is high blood pressure. Tension means pressure, and then hypo low and hyper high. Put the blood pressure cuff on, and there's an arrow on that cuff where it should be lined up with the brachial artery. And then we pump up the cuff with that sphygmomanometer until we check first, do a little test to make sure the when we feel the pulse go away, then we know how far to pump it up. 10 millimeters of mercury is how it's read. And then we release the valve and we listen for what we call Korsakoff sounds, and the first sound and the last sound will determine the blood pressure. Nowadays, we often use a automatic or electronic blood pressure cuff. And you see a lot of people have those at home too, because it's really hard to read their blood pressure by yourself using the blood pressure cuff. Angio, vaso, vasculo are all vessels. So an angiogram. So that means we're going to look at a picture or study the vessel. Could be a spasm, vasospasm, and vascular pertaining to the vessel. Aorta. Aorto is aorta, aortic pertaining to. Arterio is artery. Sclerosis is hardening. So arteriosclerosis is hardening of the arteries, typically by that plaque, which athero is a fatty lipid paste. Atheroma, it'd be a tumor of the fatty paste. So atherosclerosis is often used as well. Atrio is atrium, atrioventricular, pertaining to both the atria and the ventricles. Cardio is heart, so cardiology, study of the heart. Corono, circular. Coronary, pertaining to the arteries that are in circular nature. Myos, muscle, so myocardials, pertaining to the heart muscle. Pector or stetho both mean chest, so pectoral is pertaining to the chest. Stethoscope is something that you're going to use to scope would mean to examine or see, so we use a stethoscope to listen. Sphygmo is pulse, so the sphygmomanometer would be the blood pressure cuff. Thrombo is clot, a cell clot, thrombocyte. Veno and phlebo is both vein, so venous, and phlebitis is inflammation of the vein. Varico is swollen, twisted veins, varicosis. So then we have her tiny two swollen veins. You can see this picture here. The back of that right leg has very treacherous, twisted veins, varicose. Ventriculo is the ventricle, which also means belly or pouch. When we look at aneurysm, that is going to mean a bulging of a area of an artery. So like on the left, a normal, and then one that has a aneurysm that's bulging is what we would call fusiform. It's on both sides. Saccular would be like a little sac one-sided. And dissecting means that it's within the layer. If you can see that layer, often it's a weakening. It could be caused by certain conditions. Somebody could be born with them. It could be what we call etiology unknown. Etiology meaning a reason we don't know. This is a mitral valve that it's infected with bacteria. So bacterial endocarditis, so that looks like kind of cheese on there. That's not normal. And then so that valve's not going to be able to function correctly. It's also known as a vegetative valve. It could be from injecting some kind of bacteria into the veins. So a lot of our IV drug users will end up getting endocarditis related to substance that's in there. There's a picture of varicose veins. So again, those tortuous, twisted veins, and then that's going to decrease circulation. So then you can see here some of the valves and some of the veins, how it's supposed to open and close and does not. And typically we see those in the lower legs. We can see those in other areas, like even in the intestine and the rectal area. Coronary artery disease is going to be buildup of plaque in the artery. So you can see here on this picture, one of those major arteries that we see on the outside of the heart, the left anterior descending artery there's a plaque buildup. So people that have CAD are going to be at risk for having an MI, a myocardial infarction, which is a heart attack. This shows you here how different things can cause decreased perfusion. You can have a constriction, narrowing there, pushing in, something's pending or pushing on that vessel. The plaque buildup on the inside, a clot forming, a thrombus, and then an emboli would be a clot that's moving along. So that thrombus was formed due to the sluggish area of plaque, and the other one could have been a thrombus that originated somewhere else, but now that it's moving is what we call an emboli. We can visualize the veins by injecting dye under what's called a cardiac catheterization. So typically they go into the femoral region, so the femoral vein or artery, but they can also go brachial or radial in the wrist. And the goal there is to see areas that lack perfusion. And at that time, they can do a cardiac intervention, so what we call a stent or ballooning to get that plaque out of the way. A stress test is where they're going to exert stress on the heart. If a person is able to, then they can run on a treadmill to exert that heart. Not everybody can do that. They might have leg problems, vascular problems. So we can also inject medication that would mimic that the heart is being overworked, and then that medication will put the stress on the heart and see what they can tolerate or can't. An ECG or an EKG, this is where we're going to look at the waves of the heart. So what we refer to in the electrocardiogram is the PQRST. The P wave is the first complex, and that represents atrial depolarization, where PR interval is the time between the beginning of the P and the beginning of the QRS, which is the spiky part. And the QRS represents ventricular depolarization. And then following that is the ST, which is between the QRS and T. And then the T wave is the next deflection after that, which is ventricular repolarization. So this is how we can also determine if somebody is potentially having an MI, a heart attack. We can also see some other disturbances, whether it's related to a chemical imbalance or electrolyte imbalance, medication sometimes. but it gives us a kind of a clinical picture of the heart's activity for contraction, relaxation, and in between. So we can keep an eye on a patient when they're in the hospital, and we continuously monitor it. A lot of times we're on what's called a telemetry. So these would be some of the waveforms that we see. The very top is a normal one. Remember bradycardia. Brady is going to be slow, so the heart beat or the heart rate is slower. Fibrillation is what we consider like a chaotic rhythm that's not compatible with life. So eventually that heart's going to stop and flutter. Atrial flutter. In between our QRSs, it's like a sawtooth pattern. And then PVCs are premature ventricular contraction. So you might have had one. It feels like a palpation in your chest, like your heart skips a beat. Sometimes too much caffeine can cause that. Too much chocolate, things that it can exert stress. And then tachycardia is the heart rate is too fast. Myocardial infarction, again, would be a heart attack. So you have an area where the vessels should have perfusion or blood flow through there. And then that is stopped by something or decreased. And so eventually that area that is lacking oxygen, which is ischemia, will become infarcted and necrotic and result in cell death. So when we look at that EKG, this kind of gives us, when we look at the waves, that QRS is a spike up, and then down we look at that T wave. So when we see that T wave there kind of go down, that's what we call zone of ischemia, which is lack of oxygen. And then when we see the ST elevated, and often referred to as a tombstone or a rocking chair, that's where we know there's injury. There's not enough oxygenation there. And then down below, the dead zone or necrotic zone, you can see that rocking chair is there, but also that T wave is higher. It's not inverted anymore. So an angiogram would be the cardiac catheterization, where again, they're going to go in and look at the blood flow or the vessels. So you can see on the bottom there that they're injecting dye and highlighting that area. And they can do a percutaneous transluminal coronary angioplasty, PTCA. A lot of times now they can just call it PCI, percutaneous cardiac intervention, because they can put in stents and you're going to reroute that blood flow. So again, PCI. So here at the top, you can see where they're putting in between the plaque a catheter, and then that catheter blows up a balloon, and then see there's a meshy, wiry thing that's a stent. They're going to leave that stent in there and pull out the catheter, and that stent's going to keep that area open so that patient has adequate perfusion. Some other cardiac interventions would be defibrillation. So that's going to be where we're going to shock the heart. So the heart, if it's in what we call a rhythm that's not compatible with life, or if the person has, nowadays sometimes you don't have to read the rhythm. You can have what we call a ICD, or an automatic ICD, where you're going to put a machine on there and it's going to read the rhythm for you. So the goal is to take the rhythm ventricular fibrillation. So we say VFib, DFib. So the only thing that's going to reverse it or save that person is to do defibrillation, which is with an electrical shock of joules. So it depends on the machine. You can have one where we turn it up to 360 and it gives shocks, or we have lower ones that gives a shock at a lower level. And monophasic, biphasic, what direction does it give the shock inside the body? So, and then cardioversions, where we're actually kind of restoring or restarting that heartbeat. So there's on that machine, there's a button called synchronization, and then it's going to shock at the QRS at that spike and start the SA node, which is the pacemaker of the heart. If they have an implanted cardio defibrillator that's in their body, And it'll sense also when they need to have a shock and put their rhythm hopefully back into normal sinus rhythm, as well as a pacemaker to keep the pace. So a lot of times it's a slow rate or another rate, and those two are combined now too. We could put an ICD/pacemaker. An ablation would be to deaden an area that's firing off the wrong rhythm, and so we'll go in and either you can use heat or you can use cryo cold. Coronary artery bypass graft with CABG. So when they say CABG, it's not a vegetable, but it's a procedure to take this area that has a blockage and take a vessel from that patient's other part of their body and reroute it. So you're bypassing it, you're creating a bypass. So if there's a traffic jam on the freeway and we need to get around that, we're going to reroute it or do a bypass. So often they'll use the mammary artery, which is in the upper arm going towards the breast, and then the saphenous vein, which is out of the leg. We see that most common. So this one would be a when you hear people, they say, oh, I had a quadruple or a triple or a double bypass. So here you can see there's two areas of bypass there. When we look at some of the drug classes that we give, ACE inhibitors would be angiotensin converting enzymes. They suppress the conversion of angiotensin in the blood by the ACE. So it's used in the treatment to decrease blood pressure. Antianginal is a drug that's going to dilate the coronary arteries to help increase oxygen to the tissue. So it helps relieve chest pain, which is angina. Antiarrhythmic, it's going to counteract a dysrhythmic, abnormal rhythm, and hopefully keep that patient normal. Anticoagulant's going to keep the blood thin so they don't form clots. Antihypertensive is another class of drug to keep the blood pressure low. And then beta blockers inhibit response to sympathetic adrenergic nerve activity, slowing the electrical conduction and heart rate, and lower the blood pressure as well. Calcium channel blockers inhibit the entry of calcium ions into the heart muscle, again, slowing the heart rate and lessening the demand for oxygen and nutrients, and relaxing smooth muscle, which will result in dilation. Cardiotonic is a drug that increases the force of the contractions in the heart. We use that a lot with congestive heart failure. Diuretics are meds that are going to get rid of the body fluid, so it's going to increase secretion of urine, which is going to help the heart if it has too much fluid like we see in heart failure. Hypolipidemic or hypolipidemia would be where somebody has increased fat and cholesterol, and this drug is going to help reduce that. Thrombolytic agents dissolve blood clots. Streptokinase or tissue plasminogen activator, TPA, where anticoagulants just kind of stop the blood from coagulating, forming clots. Thrombolytics will actually dissolve the clot. Vasoconstrictor is going to narrow blood vessels, decreasing blood flow, and vasodilators are going to dilate the blood vessel, increasing blood flow. Abbreviations that we see, ACS is an acute coronary syndrome. So anybody that has chest pain will be given a diagnosis of ACS until they figure out what's going on. ASD is atrial septal defect. So they're going to have, and the septum have a defect. BP stands for blood pressure. And then that CABG, again, is coronary artery bypass graft. CAD is coronary artery disease. CHSF is congestive heart failure. CO is cardiac output. DVT is a deep vein thrombosis, so they have a clot in the lower leg. And ECG and EKG are both electrocardiogram. Both are acceptable. Echo is an echocardiography or echocardiogram. HTN is hypertension. ICD is that implantable cardioverter defibrillator. Intravenous is IV. MI is a heart attack, myocardial infarction. NSR is normal sinus rhythm. So when we're looking at the heart, we want that normal sinus rhythm. Percutaneous coronary intervention is PCA, where PTCA is where they have the percutaneous transluminal coronary angioplasty. PVC is a premature ventricular contraction, so you might feel that palpation. SA is the sinoatrial, and often the node. SCA is sudden cardiac arrest. And stroke volume as SV. And I think that's it for chapter 9.